Live होगी. It's live now. Should we start, Dr. Vipul?
Yeah, please go ahead.
Good morning, dear friends. I welcome once again all of you to this session on child with thrombosis. What kind of approach we should have. And before that, I request all of you to please fill that Google form for the workshop on 3rd of September, which is going to be held at Chacha Nehru Bal Chikitsalayah. It's just across Red Fort. If you cross River Yamuna, you'll reach Chacha Nehru Bal Chikitsalayah. We have Dr. Tulika Seth with us. She is director at the Department of Hematology at AIMS, New Delhi. She'll be speaking about the approach to a child with thrombosis. I welcome her and request her to please start sharing her screen. Thank you, ma'am.
Thank you. And I am delighted to participate in this certificate course of hematology. And the topic I'll be talking about today is an approach to a child with thrombosis. And I'll discuss some of the current concepts in diagnosis and management. So why does thrombosis occur? Thrombosis occurs because there are changes in the blood flow that is either related to the red blood cells or due to stasis. And there can be changes in the vascular wall. There can also be changes in the levels of the coagulation factors or their inhibitors. Now, we know that endothelial injury and platelet functions are important for arterial thrombosis. And the stasis and disorders of the coagulation fibrinolytic system are important for venous thrombosis. So why does thrombosis occur in children? Children are just like adults, they can also have thrombosis. Usually we consider this to be rare. In adults, thrombosis is much more common. We see thrombosis in adult patients and teenagers in about 1 in 1,000, particularly in children and adults who are in the hospital. This incidence is increasing worldwide. Currently, the estimates are that pediatric patients, 5.3 per 10,000 children who are presenting to hospitals do have thrombosis. And all of it is not only in the newborn and neonatal period. A lot of this is older children. And this may come as a surprise because we generally feel that only newborns are the childhood population that can have thrombosis. So why is this happening? This is happening because more and more children are coming to ICUs, are critically sick. There are a lot more interventions that are being done, a lot more lines are being put, and this is leading to the higher rates of thrombosis that are seen. What kind of venous thromboembolic phenomena are seen? The most common blood clots seen in children are deep vein thrombosis. Then we have central venous sinus thrombosis. Isolated pulmonary embolism is not very common in children. And then they can have other sites of thrombosis as well. So why is thrombosis dangerous? Well, thrombosis can lead to higher mortality risk as well as the morbidity. And the morbidity can be both acute as well as chronic. And patients can have post-thrombotic syndrome due to this problem. So, as I said, they can have different problems. Occasionally, we can have patients who have pulmonary embolism along with a symptomatic deep vein thrombosis. Paradoxical emboli can also occur. One of the problems of not treating a proper venous thromboembolic phenomena is that patients can develop recurrent thromboembolic phenomena like DVT recurrently. And that is something that is, again, going to pose more morbidity on the patient. So what ages can thrombosis occur in children? They can occur actually at any age group, but there are two peaks. One is in the newborn period, and the second is in the adolescent age group. But any child in between, especially if they're sick in the ICU, have central lines or underlying disorders, can develop venous thromboembolic phenomena. So what are the challenges of this? As we said, it's fairly rare, and there are a lot of things that are still unknown about it. A lot of the recommendations that we have for management are extrapolated from adults, and there are additional problems with children, which I'll discuss further. So it's important to remember that children are not simply small adults. There are differences in the epidemiology of venous thromboembolism. There are also differences in the hemostatic system in children, because we know that in the newborn period, even the levels of protein C, protein S, antithrombin are different. The responses to the anticoagulation drugs are also different because of the distribution and binding and clearance. And so we really need to be able to have studies that are based on children, so that all of the interventions we do are evidence-based. So just going back to Virchow's triad, the thrombosis occurs because of alterations in pro and anticoagulant and also the fibrinolytic systems. The coagulation cascade that we used to think about as the intrinsic and extrinsic pathway has now moved on, and we now look at this as a cell-based coagulation in which platelets, endothelium, as well as the coagulation factors play a role, but I won't go into that in detail. But I would recommend that all the students study this, because this gives us a better and more physiological understanding of coagulation. So why, again, is it important to understand the different ages of the children that you're dealing with? As I said, the protein C, protein S levels are low at birth. And in fact, it doesn't even approach the adult value till about 6 months for protein S. And protein C levels remain low all through childhood. Plasminogen levels are also low, and the thrombin generation is decreased. So there are several differences in the infants. And when we deal with adolescents, there we are more likely to be looking at a coagulation system that is more like adults. And that's why adolescents have a second peak, which is again similar to adults. So a little bit on terminology. So when we say VTE, we're talking about venous thrombosis or venous thromboembolic phenomena. DVT is acute deep vein thrombosis. When we talk about a provoked venous thromboembolic phenomena or DVT, that is when we have a known risk factor. So a provoked DVT could be due to a central line, due to trauma, due to surgery. When it's unprovoked, that means that we don't have any known underlying intervention. So there's no bed rest, there's no trauma, there's no central line. An unsuspected DVT or VTE is one that is asymptomatic and found on screening. Recurrent means more than one event, and chronic means that it's long-standing, it's not acute. And these chronic DVTs can sometimes be found on imaging, and they do not respond to anticoagulation. A post-thrombotic syndrome is a sequelae of an acute DVT or VTE, and this basically includes lung skin changes and vein changes, and often is accompanied by pain and swelling, but again does not respond to anticoagulation and is a sequelae. So what are the precipitating factors for venous thromboembolic phenomena? Venous thromboembolic phenomena can be provoked by a major and transient risk factor. This could be present around 3 months before or around the time of the event. It could be provoked by a minor transient factor, which might be acutely present. It could be provoked by a persistent risk factor, and you could have unprovoked venous thromboembolic phenomena. So what are the major risk factors or the major provocation that we see? So indwelling catheters are one of the major things that we see. So deep vein catheters, central lines, PICC lines, all of these are culprits. Infections are another major predisposition because there is inflammation and there can be other changes that occur. Any major surgery, DIC, post-infectious transient antiphospholipid antibodies can also lead to thrombosis. And many congenital heart diseases also have these children with a procoagulant kind of a provocation. Other things like nephrotic syndrome and other diseases are also likely to lead to thrombosis. So who are the children and which setting are we most worried about thrombosis? All patients who are in the ICU and NICU, cancer patients, again, because the cancer itself can lead to an increased risk of thrombosis, as can the central lines and some of the chemotherapeutic agents that are used to treat the cancer patients. Trauma is again another area. Congenital heart diseases we've already talked about. And some acquired heart diseases like Kawasaki, dilated cardiomyopathy, and COVID-related MIS-C are other scenarios where thrombosis can occur. So if patients have an inherited thrombophilia, this is usually rare in the pediatric population, but we do see patients with protein C, protein S deficiency. We see patients with sickle cell disease and thalassemia intermedia, post-splenectomy. But the other inherited thrombophilias rarely contribute to thrombosis in the younger children, though they may be risk factors in older children, like in teenagers. The majority of pediatric patients have acquired conditions like antiphospholipid syndrome or catheters, nephrotic syndrome, leukemias, inflammatory diseases, infections, etc. In the newborn, because again, this is an area where not only can thrombosis occur, but it can have serious sequelae and it can be hard to diagnose. There are many risk factors, especially for things like renal vein thrombosis and polycythemia, dehydration, maternal gestational diabetes, asphyxia, sepsis, and the changes in the protein C, protein S levels that are seen in these patients, even the physiological ones, and of course, those patients who have congenital deficiency of protein C, protein S, and AT3 are going to be at a higher risk of developing thrombosis in the newborn period. So those were the settings. Now, how do we make a diagnosis when we suspect that there is a thrombosis? So first of all, it's often unsuspected, so we need a high index of suspicion. Imaging is required for diagnosis, and that sometimes is difficult because you may need to use anesthesia in order to do the imaging. Because of the size of the patient, sometimes that again is a problem. So most important is to keep a high index of suspicion. Earlier, a lot of data was based on autopsy data. So obviously that is something we don't want to miss. The other issue is that often in pediatric patients, the symptoms may not be very specific. So children may just have tachycardia or tachypnea or chest pain. So even a pulmonary embolism may not really have the all the signs and symptoms that you would expect, because children often don't complain of pain, and so you really need to monitor them. And in children who have pulmonary embolism, often there may be no deep vein thrombosis that is accompanying. In adults, usually you'll have a deep vein thrombosis in perhaps the lower limb, and then you may have a pulmonary embolism. So in adults, they're often concurrent, but in children, you may have a silent pulmonary embolism, particularly in a very sick child. So how do deep vein thrombosis present in children or adults? These usually are easier to diagnose than a pulmonary embolism, and usually there'll be swelling and pain and color changes in the limb. And but if you have, for example, a superior vena cava thrombosis, this will present again with swelling in the upper limb and pain and sometimes superficial venous dilatation. There may be facial swelling, and sometimes they're related to a central line, so you can suspect them. Renal vein thrombosis, patients can present with hematuria, oliguria, and enlarged kidneys. Cerebral vein or venous sinus thrombosis presents with headache, seizures, hemiparesis, coma, and increased intracranial pressure. Hepatic vein thrombosis is rare, but such patients can present with abdominal pain, vomiting, hepatomegaly, abnormal LFTs, and sometimes ascites. So the symptoms need to be looked for. The commonest symptom is edema. It's mostly seen, and if that is there, it's usually a very specific symptom. Leg pain can occur, but sometimes it's not present, and the pain can, even though we would expect there to be a lot of pain, but in children, often the pain is not non-specific. Tenderness is there, so it's, if you are examining the child, you may be able to elicit this tenderness, and warmth and erythema can be there. So as I said, the symptoms of pulmonary embolism are usually sudden breathlessness and chest pain, but we often have patients who don't have the classic symptoms, and sometimes you may pick up some of these lesions on imaging. So the symptoms will obviously vary according to the site of the thrombosis. So you need to have a high index of suspicion, because pain in any of these areas could be due to a multiple other causes of for these children in the ICU. But think about thrombosis as one of the other factors. So this is this is a table which is again highlighting the different symptoms that you can find in the different settings. So you need to make sure that you're doing a thorough repeated exam in these patients. The signs that you can elicit, the classic sign or the Homan sign that is there, in which there's calf pain on dorsiflexion of the foot. Many times there can be discoloration of the lower limb, and you may be able to feel an indurated cord-like vein. But again, in children, these are signs that often are not always there in the acute setting, and they may be difficult to elicit. But in older children, you can definitely do that. But in the pediatric patients, often these signs are very subtle. The pulmonary embolism, I need to keep re-emphasizing, because the high risk of mortality with this, often there can be just some ghabrat or apprehension, diaphoresis, tachycardia, tachypnea, chest pain, and hypotension. So again, if you're not dealing with shock, this could be something that you could be dealing with. And there are specific ECG changes that can help you if you think that you may be dealing with this. Now, in children who are in the ICUs, you can identify unsuspected venous thromboembolism. And this basically means you're picking up a thromboembolism which is asymptomatic, but on screening imaging. So obviously, this will only happen if you are screening these patients, but it's important to know that the treatment for these asymptomatic venous thromboembolism remains the same. And we don't know the exact incidence because screening is not done regularly, but wherever it has been done and these patients have been identified and treated appropriately, the outcomes have been good. So there are some studies where they looked at it and they found that there's up to 17% of patients can have these asymptomatic venous thromboembolism, and the risk factors for this usually is seen in patients who are 3 to 7 years of age or premature babies, And often it is seen in patients who have a diagnosis of cancer or have the central lines for a longer duration. Now, how do we investigate? The usual modality that we use for diagnosis is a Doppler ultrasound. But again, in children, it can be difficult, especially for the upper limb. The Doppler ultrasound can often give you a false negative. That's because of the position of the clavicles and the thoracic cage, and everything is just smaller in children, and so you may miss things. For the lower limbs, the Doppler venous ultrasound is very good. And for a lower limb, it's definitely the initial investigation of choice. If it's an upper limb, then you may want to do a CT scan or other imaging to make sure you're not missing if you have a high index of suspicion. The contrast angiography is the gold standard, but again, it's difficult to do, and hence in pediatric patients, the color Doppler is usually used as the initial investigation. An MR venography can sometimes be done, but for obvious reasons, this is only done if you have a very high index of suspicion, because it's not a good screening test. So when do you have a high index of suspicion? One is, of course, the setting of the child. So if it's a sick child in the hospital, and you can do a D-dimer and coagulation test. So how does the D-dimer help you? If the D-dimer is high, you may be dealing with a thrombosis, but D-dimers are raised, as we all know, in many other scenarios. If the D-dimer is negative, it has a very good negative predictive value. So you're probably not dealing with a thrombosis if it's negative. But if it's positive, again, you need to then screen to identify it, because this would not be a diagnostic test for a thrombosis. It would just give you an idea that probably you have a pretest probability that could be high. And the coagulation test for hypocoagulation can sometimes be useful. So if you have a low pretest probability, you'd only do a D-dimer. If you have an intermediate to high pretest probability of a lower limb DVT, then you can do a Doppler ultrasound of the lower limb. If you have an intermediate or high pretest probability of a pulmonary embolism, then you need to go for the diagnostic imaging, the VQ scan, or a helical CT scan or pulmonary angio. So what are the laboratory tests that help you understand what is the underlying cause of a thrombosis? So first of all, in the acute setting, all of your thrombotic proteins will be deranged. So when you have an acute thrombosis, you will see a protein C, protein S, and 83 at low levels. And that could be because the patient actually has low levels, or because they have been consumed in the acute thrombotic setting. So in an acute thrombosis, we do not usually test for protein C, protein S, and antithrombin 3, unless, of course, you're thinking of a congenital deficiency of these factors. The other thing is that if you have an acute and serious thrombosis, you will start some anticoagulation. And whether you're using heparin or low molecular weight heparin, or you're using a vitamin K antagonist, these will also interfere with your test. So in general, if you want to test for the etiology of a thrombosis, we wait for a minimum of 3 months. We don't do the testing immediately unless it's going to be in a life-saving scenario, for example, congenital protein C, protein S deficiency. But in case you do want to do the testing, the molecular testing for factor V laden, prothrombin mutation, lipoprotein A, homocysteine levels, and beta-2 glycoprotein can be done even in patients who are on the anticoagulation. But protein C, protein S levels, if you're doing it, and if it's low, if it's mildly low, then you don't know if it's due to an actual deficiency or if it's due to just the consumption. If it's absent, then of course it is likely to be due to a congenital deficiency. So the inherited thrombophilia testing is something that we get a lot of questions about. In adults, we definitely do testing for factor V laden and the other inherited thrombophilia. If you have a pediatric patient and you think you have a central venous catheter-related thrombosis, and this is the first episode, we usually do not recommend the testing for factor V laden and the other thrombophilias. If you are sure it's not a central venous catheter and there's no other risk factors that are identified, then you may definitely consider doing the testing, because that you may be able to find a cause and that may impact on your treatment. If it's a recurrent deep vein thrombosis, then it is again, and you don't have any other ongoing persistent risk factors like nephrotic syndrome or congenital heart disease or any other, or cancer, then again, it is recommended to do the inherited thrombophilia testing. So just to reiterate, if it's a central venous catheter or a first episode, then the inherited thrombophilia testing for factor V laden and others is usually not recommended. So what about testing if we have a positive family history of a inherited thrombophilia? So we often get these families where there is a relative who has had a deep vein thrombosis and they've been found to have a inherited thrombophilia mutation. So if the child is healthy, even if they have a strong family history, we don't recommend doing the testing. The only thing is that once these children become teenagers, so particularly if it's a girl and you're planning to use some sort of birth control or estrogen-containing contraceptives, then it might be something that you could counsel them that they can get tested as they get older. And majority of the venous thromboembolic phenomena we see in pediatrics is due to acquired risk factors and not due to the inherited risk factors. And so you're basically just spending money and you're not really going to pick up a lot of things that are going to be important. The majority of venous thromboembolism we see in children is provoked. So that is aside from the protein C, protein S, and AT3 deficiencies. And so the inherited thrombophilia are really only important in the teenagers or when we have recurrent DVTs. So in daily practice, this is a very nice study from Turkey where they actually investigated and they found that a lot of patients actually got tested for the thromboembolism, and they found that even in patients who had the risks, the contribution was very little. So in general, it should only be performed if you feel that it's going to change your treatment, and it's not like in adults where it's going to contribute, and the only thing it really helps is to increase the anxiety in the family and the patient. So as I said, this is just a summary of that. So most of the time you have a possible triggering acquired factor, and that should be investigated carefully. And if case you don't find anything, only then you should go for the inherited factors. And so if you have a family history of a thrombosis, and you have a DVT, then of course you need to investigate. So this is a child with a DVT and a family history would be somebody that I would definitely investigate. Can you do harm by testing? Yes, you can, because there's a lot of anxiety that has been associated, and it showed that there was a study that looked at the anxiety, and the anxiety increased from 27 to 43% in the adults. And this anxiety of having a risk factor for thrombosis was only a little bit less compared to the risk factor of an inherited breast cancer. So that is one of the reasons why it is not necessary to perform the inherited thrombophilia testing in children less than 15, in children who have not had a thrombosis, but have only a family member who has a risk for thrombophilia. So even though we always think of protein C, protein S deficiency as inherited, you can see an acquired protein C deficiency, particularly during the acute thrombosis period. You can see it with warfarin therapy. You can see it in liver disease and vitamin K deficiency, and some DIC patients and sepsis patients and patients who are on drugs like L-asparaginase and anticonvulsants like sodium valproate may have protein C deficiency, and we sometimes see inhibitors of protein C in post-transplant patients. So it's important to understand that it may not be a permanent deficiency that you're seeing, and it may be something treatable, particularly if this is found in patients outside the newborn period. So now that you've made the diagnosis of a child with a thrombosis, you now need to treat the patient. So treatment is often difficult in the children because many of the formulations for the vitamin K antagonists or the other low molecular weight heparin and even the direct acting anticoagulants are not really pediatric based. So there's not a lot of suspensions and liquid preparations. We also know that breast milk and infant formulas can have vitamin K in it. They can often be compliance issues. And even the low molecular weight heparin, which comes in very convenient pre-dose syringes for adults, is not available in pediatric dosing. And in case you need to do thrombolytic therapy, which is not frequently required, but in a severe pulmonary embolism and a patient who has decompensation, you may need to do thrombolytic therapy, and that's often difficult in children because of the smaller veins. So whenever we're looking at guidelines, it's important to look at PICO, that is the patient, the intervention, the scenario. There are a lot of guidelines, and when we're treating a patient, there is the initial phase that you need to think about, and then there would be the treatment phase, and in some conditions you may want to have a continuation phase. In general, most acute thromboembolic phenomena, we recommend about a 3-month treatment. More than that is usually not required except in special scenarios. So how do we treat? So the initial thing would be obviously to observe and then decide what to do. If it is a central venous catheter, often the only thing you need to do is to remove the offending catheter. Many patients will require anticoagulation. Some patients may require a thrombectomy, which could be pharmacologic, mechanical, or surgical. In some of the management, they are expert-based, and a lot, though now we are having more and more studies in the pediatric patients on specific treatments. So there are still some unmet needs. We know that anticoagulation can lead to bleeding. We know that post-thrombotic syndrome can occur even in about half of the patients. There is unfortunately not very good treatment for that. Patients who have had pulmonary embolism can go on to develop pulmonary hypertension. So there are still a lot of issues with the treatment, and that is both in adults and pediatrics. Now, for treatment, one of the long-standing agents that we've used are vitamin K antagonists, warfarin and acetrom, and they're still very important and very useful agents. We always start with a heparin, and that is because when you start with vitamin K antagonists, there is a further decrease in protein C, protein S, which can exacerbate the thrombosis. So before using a vitamin K antagonist, you always bridge with heparin, either unfractionated or mostly with low molecular weight heparin, you always should do a liver function test in CBC, a liver function test, because if the liver functions are deranged, then you might want to avoid vitamin K antagonists because you may end up with more bleeding. CBC to make sure that you're not missing thrombocytopenia or any other problems. As I said, you must overlap with a heparin. You need to monitor the prothrombin time and the INR. We usually aim for an INR between 2 and 3. And always look for drug interactions, because often these children who are having thrombosis may be in the hospital, they may be on antibiotics or other agents which will cause problems. So low molecular weight heparin is the preferred heparin that we use nowadays. Enoxaparin is easily available. We have the innovator in many generics. Fondaparinux is often also used. And the advantage of enoxaparin is that it has it has a short half-life. So if you want to stop the anticoagulation, you can simply miss a dose. Otherwise, it's given twice a day. And these are the doses of low molecular weight heparin that we give. If we're using it for treatment, it's 1.5 milligrams per kilo per dose, and it's given twice a day. In less than 2 months old, in between 2 months and 18 months, it's 1 milligram per kilo per dose twice a day, which is similar to the adult dosing. And in the newborn period, again, the prophylactic dose is again a little bit higher than the prophylactic dose we use in older children and in adults. Usually we don't need to monitor low molecular weight heparin, but there are several scenarios where we might want to monitor, and that is if the patient has renal dysfunction, if the patient is obese, and in the newborn period. And if you do need to do that, there is a specific anti-10A assay that can be done, and you want to keep the therapeutic range between 0.5 to 1 units per ml. Patients who have heterozygous protein C, protein S deficiency are sometimes identified. And there's often a lot of questions on how do we manage these patients. So if there is no thrombosis and a patient is only identified as heterozygous protein C, protein S deficiency, then we don't give prophylactic anticoagulation unless they are in a scenario like where they're going to get cardiac catheterization or L-asparaginase therapy, or they're having a major surgery. Only in those cases we would put them on prophylactic anticoagulation. That would be the half dose of lower molecular weight therapy. But otherwise, prophylactic is not recommended unless they're in a high risk situation. If they do develop a thrombosis, then they are treated with low molecular weight heparin, and they are treated as other children without the heterozygous protein S, protein C deficiency for 3 to 6 months, and that can then be tapered off, unlike patients who have homozygous protein C, protein S deficiency. So this is a algorithm of what we do for patients who have central venous catheter thrombosis, and it's not projecting very well, I apologize. But basically, when we have a patient who has a central venous line thrombosis, start anticoagulation for 1 or 2 days and remove the line. And often long-term anticoagulation is not required unless there are ongoing risk factors, in which case then you can continue it for 3 to 6 months. So so if you have an asymptomatic patient who has a thrombophilia, it's important to see what is going on. You can manage these patients with warfarin. You can manage these patients with, if you have, for example, antithrombin deficiency, there is antithrombin available. If patients have protein C, protein S deficiency, then that concentrate is also available abroad. Though in India, we would end up with only anticoagulating these patients because we don't have the antithrombin and protein C, protein S available for us. Now, a lot of people ask about the direct acting anticoagulants. A lot of the data earlier was extrapolated from adults, but we're now getting some studies in pediatric patients as well. And I just wanted to mention that when these DOACs were initially approved, we were very excited because we said we don't need to do PT-INR monitoring, and the companies told us that there was less risk of severe bleeding. With more experience, we've realized that the risk of severe bleeding, that is intracranial hemorrhage, is actually the same with vitamin K antagonists and the direct acting anticoagulants. So there is no safety measure in this. And menorrhagia is actually increased when using the DOACs compared to the vitamin K antagonists. And there are several scenarios like in APLA syndrome where we don't have data of the DOACs. And formulation, of course, is still a problem. And the additional thing is that in case there is an overdosing or bleeding associated with the DOACs, then reversal is much, much more difficult with these agents. So you need to be a little bit careful. Some people use the term newer oral anticoagulants, but ISTH, which is the International Society for Thrombosis and Hemostasis, recommends we use the direct acting anticoagulation, or the DOACs is the specific term. And there's two major groups. There's the direct thrombin or 2A inhibitors like dabigatran and argatroban. And then we have the direct factor 10A inhibitors like rivaroxaban, apixaban, endoxaban. And the dosing is fairly similar to what is recommended for adults. Now, what happens if you get bleeding with a DOAC? The dabigatran has a specific antidote. This is unfortunately not available in India. And even if it were available in India, it costs about 3,500 for a dose. So that's something that you have to remember, that you can't reverse it simply by giving FFP or vitamin K. There is a modified 10A inhibitor. And the other thing that can be used if you're not able to use these specific inhibitors is that you can use 4-factor APCC, which contains factor 2, 7, 9, and 10. Sometimes you can use cryoprecipitate. If you're using a vitamin K antagonist like acetrom or warfarin, then you can give vitamin K. Or if the PT-INR is extremely high, you can give FFP. If you're using unfractionated heparin, then you can use protamine. If you're using low molecular weight heparin, protamine will reverse about 50% of that. And as I said, most of the low molecular weight heparins have a short half-life also. So these are guidelines on how to manage bleeding. If it's mild bleeding, then you maybe just hold the next dose. If there's moderate bleeding, then you obviously need to stop the anticoagulant. You may need some apply pressure. You may need to give fluids and replace volume, and you may need to even give blood transfusion. And if it's a severe, then you definitely would want to look at either a 4-factor APCC or a specific specific antidote that is needed. And these are some of the other measures that can be done. But as I said, most of the time it's not going to be available. What we do have in India is we can give FFP and human fibrinogen. We do have APCC that can be used or FEBA that can be used, but the specific antidotes are, as I said, not available. Now, to summarize some of the guidelines that are recommended. So if you have a central venous catheter associated thrombosis, what do the different guidelines say? So we have the American Society of Hematology guidelines, the CHEST guidelines, which are the Cardiology Society, and then we have the UK Society. So most of the guidelines recommend to start anticoagulation, leave the catheter for a few days. If it's functioning, if it's not functioning, then after 1 or 2 days of starting the anticoagulation, you can then remove it. In the ASH guidelines, they say to remove the catheter if you have an alternative venous access. If not, they say remove after several days of starting the anticoagulation. It's not a good idea to remove it immediately because you may dislodge the thrombus. The CHEST guidelines are fairly similar. They say remove after 3 to 5 days of starting anticoagulation. And they say to give 6 weeks to 3 months of anticoagulation for a line. And if there is a right atrial thrombus, then they definitely recommend to remove the line with or without anticoagulation. So this can sometimes occur and needs to be treated. The UK guidelines say to remove 2 to 4 days after anticoagulation, and they don't recommend any further anticoagulation after that. So there are some differences in the guidelines. If you have a major deep vein thrombosis or a pulmonary embolism, all of the guidelines recommend anticoagulation. In the American Society, they recommend therapy of 3 months, or if it's provoked, then a little bit less. They don't recommend thrombolysis or thrombectomy unless it's a massive pulmonary embolism. And the CHEST guidelines recommends 3 months of therapy for a provoked venous thromboembolism and 6 to 12 months if it's an unprovoked deep vein thrombosis or pulmonary embolism. So in general, if it's unprovoked, we give a longer duration of therapy. And if it's a provoked, we can give a shorter duration. For the pulmonary embolism or if it is due to antiphospholipid syndrome, then they recommend lifelong vitamin K therapy, though antiphospholipid syndrome is rare in pediatric patients. The only indication for an IVC filter is in children who are larger than 10 kg with a contraindication to anticoagulation therapy. So in general, we've moved away from using IVC filters. And the reason for that is because once you put in an IVC filter, you then need to remove it. And if it's not removed within a few weeks, then it is difficult to remove and you may end up having to give anticoagulation to prevent thrombosis at the site of the filter because you can't remove it. So these were fairly, the UK guidelines are similar to the CHEST guidelines for the major DVT and pulmonary embolism. What about CSVT? Again, anticoagulation is common in all. In the ASH guidelines, it says anticoagulation should be given if you have a CSVT with hemorrhage. In the CHEST guidelines, it says anticoagulation only if there's significant hemorrhage or if the radiological monitoring to detect thrombus shows a progression after 5 to 7 days, then you do anticoagulation. If there's no progression, then it doesn't, and there's no hemorrhage, then you don't need to do a anticoagulation. And thrombolysis or thrombectomy or surgical decompression is only required if the anticoagulation fails. And here, usually it is given with the unfractionated heparin because these patients are usually in the hospital. And the UK guidelines, again, recommend anticoagulation if there's hemorrhage, but they also specify not to give anticoagulation if there's hemorrhage with a mass effect or intraventricular hemorrhage. So they've given a little bit more detail into which patients should get anticoagulation and which patients should not. And again, they recommend radiological monitoring. And if there's significant hemorrhage or thrombus progression, then you need to decide about anticoagulation or no anticoagulation in these patients. So monitoring is useful, and they also usually recommend avoiding thrombolysis because thrombolysis will increase the risk of hemorrhage. And what about in patients who have homozygous protein C deficiency? So as I said, protein C replacement is recommended in all. That way you can avoid lifelong anticoagulation. In the ASH guidelines, they say, again, you should give protein C replacement with or without anticoagulation. In the chest guidelines, you can give FFP or protein C because FFP would also contain protein C. They recommend lifelong anticoagulation with a vitamin K antagonist or low molecular weight heparin, or they say you can only give protein C replacement, which usually for us is not possible. And they also recommend a liver transplant. So in India, most of our patients would be on lifelong vitamin K antagonists, and the UK guidelines are similar to the chest guidelines. Now, I had mentioned that you could sometimes have a patient who has a provoked venous thromboembolism. And there is a study where they've looked at 6 weeks versus 3 months of therapy. And a lot of times people ask about whether 6 weeks therapy is enough. And even though the study says that they didn't find any major differences, but there is a trade-off between recurrent thrombosis and a risk of bleeding. So you need to be a little bit careful. And what they found was there was a increased risk of recurrent venous thromboembolism, which went from 1% to 12% in the patients who were in 6 weeks versus 3 months. So you have a higher risk of recurrence. There was a benefit in doing 6 weeks versus 3 months because the overall bleeding events were 0 in the patients who had only 6 weeks of therapy, while they were 4% in those who had 3 months therapy. So it's important to look at your patient and see the risk and decide whether you're more worried about a recurrent thrombosis. And one thing to remember is if you have a patient with recurrent thrombosis, you are now looking at lifelong thromboprophylaxis. So that is something to decide. So when we are looking at the duration of anticoagulation, it's important to look at the severity of the venous thromboembolic phenomena, the etiology and compliance and other factors to decide how long you want to treat. And often what we do is we do a D-dimer and we do repeat imaging before we stop any anticoagulation. If you still have an acute thrombus, we don't stop. We might continue more than 3 months. And if the D-dimers are very high, then again, we will continue for a few more months because, as I said, if you have a recurrent thromboembolism, then you are basically going to not ever be able to stop anticoagulation in these patients. So it's better to stop the anticoagulation in a planned way rather than risk a recurrent TVT. So in summary, when approaching children with thrombosis, you need a high index of suspicion, assess the risk-benefit for treatment, consult a hematologist. There are many treatment options that can suit the site, the lifestyle of the patient, the age, and other medical conditions. You have vitamin K antagonists, you have low molecular weight heparins, you have the direct-acting anticoagulants. Check the monitoring requirements for the agent that you're using, check the risks and contraindications. Always remember when we're anticoagulating, it's a tightrope walk because if you under anticoagulate, you may continue to have the thrombosis and you may actually get a new thrombosis in these patients. And if you stop the anticoagulation too soon, you may get a recurrent thrombosis, but you also have a risk of bleeding when you're using these agents. So you need to be very cautious. So thank you for your patient listening and make any question.
Thank you, ma'am, for a wonderful presentation. Dr. Vipul, can you see any questions there?
I am just looking.
Yeah, there are.
Okay.
We have to look at Q&A section, and there are few in chat also.
Okay. So in the chat, I'm seeing what are COVID risks of thrombosis? Okay. And I'm sorry, the light is not very good here.
I mean, you can please stop sharing the screen.
Okay. How do I do that?
I'll do that.
Thank you. Okay.
Thank you.
Okay. So I'm not able to scroll up, but okay. So the last question I'm seeing is in a patient who has pain in one calf while brisk walking, when pain occurs at a distance of 1 kilometer, 2 minutes. Okay. So I don't really think this is a question related to, this is more like a intermittent claudication kind of a question. So I think this question is not really related to thrombosis. So a patient is having pain after walking 1 kilometer, 2 kilometers, then I think you need to look at a lot of different things from muscles to other things. So I think that's not really a question of thrombosis.
Maybe spasm in the arteries or something like.
Yeah, exactly. There could be some vascular insufficiency, but but in a child, it could all vascular insufficiency is less common. I would think of other things like muscular and skeletal.
Dr. Vipul, can you see any other questions?
डॉक्टर अजय, एक तो
question on
आपके एंड पे ना
significance.
एक्स्ट्रा नॉइजेस आ रही हैं आपके एंड पे डॉक्टर अजय.
हाँ,
After stopping warfarin, for how long we should wait before sending samples for protein CS?
Excellent question. So we usually will wait for 1 month. And the reason for that is if you're sending the test, then you want it to be a reliable test. So wait for at least 1 month.
In DVT with thrombocytopenia, a low molecular weight heparin, can we give minimum platelet count to give low molecular weight heparin?
So this is again a very good question, and we have given low molecular weight heparin if the platelet count is about 50,000. And in fact, we have seen that even in ITP patients, they have a high risk of thrombosis. So even though we think about ITP as a bleeding disorder, but ITP patients can also have thrombosis. And if the platelet count is 50,000, you can use one anticoagulant.
What is INR?
The INR is the international normalized ratio. So it's basically a PT varies from lab to lab depending on what reagents they are using, what kits they're using. So often it is difficult to understand if the PT, the prothrombin time in one lab is the same as another. But when we do an INR, it is you are basically comparing that patient's PT to a normal person who's not on anticoagulation. And so this INR is a ratio of the patient who is anticoagulated to a normal person. And we want to keep that ratio between 2 to 3. So in a sense, you're almost you're making the patient's PT twice or thrice as long as a uncoagulated person, and that is the therapeutic range for anticoagulation. So if a patient is on a vitamin K antagonist, the PT INR should be between 2 and 3. If it is less than that, the patient is not adequately anticoagulated and is at risk of thrombosis. If it is more than 3, then he is over anticoagulated and is at risk for bleeding.
This is a question I'm a little confused with what percentage of venous and arterial block qualifies for testing? Please share age-wise chart. What percentage of blockage is emergency?
So in general, patients are not symptomatic until they have a complete occlusion. So, so you may find a partial block if you're doing screening, but you will not get a symptomatic patient who has, you won't really see symptoms until there's a full block. So often when you're doing a Doppler, you'll find that there's no flow. So when there's no flow, that is what we call an acute arterial or venous thrombosis.
And if you have suspected patient of pulmonary embolism who has low platelet and petechiae, what are our options in management?
So this is the hematologist nightmare. So we do have several scenarios where we have thrombosis and where we have thrombocytopenia. One is, of course, ITP. The other that we sometimes see is in DIC. The other that we can sometimes see is in PNH. So there are some scenarios where we do see this. In that case, what we would recommend to do is to give a platelet transfusion and anticoagulate. And we do that in a lot of patients, and you can get them through the initial, danger period by doing daily platelet transfusions to cover the thrombocytopenia. If you can keep the platelet count about 50,000, then you can easily give low molecular weight heparin. If the platelet count is lower than 50,000, give platelet transfusion and give the low molecular weight heparin.
Dr. Kamaljeet, anything you would like to further ask in this question?
Sir, no, thank you, ma'am. Thank you so much. Yeah, that's all.
Two people have raised their hands, Dr. Didel and Dr. Anas.
बस
I'll
एक
ask
क्वेश्चन
because
उससे पहले क्वेश्चन ले लूं मैं ये जो है
Sure.
there are sudden deaths in COVID these days. Are they anywhere related to thrombosis? If yes, any factor variation that has been observed in some cases of these sudden cardiac deaths?
So again, an excellent question. We don't have data on pediatric patients, but we have seen in adults that they can have an increased risk of both arterial and venous thrombosis. We don't understand the exact etiology of thrombosis in COVID. What has been actually found is that doing thromboprophylaxis, like what we do in the ICU, either full dose or half dose, has actually not helped. So low molecular weight heparins do not help to prevent this thrombosis. Neither has aspirin been shown to prevent it. So this is probably due to a new phenomena that has been discussed, which is called thromboinflammation. And so it is the actual inflammation itself which is leading to the thrombosis. And that is why simply giving an anticoagulation doesn't help. I think in pediatrics, we just need to observe and we need to follow these patients. If the D-dimer is persistently high, then this may be a warning that something else is going on. The other thing to remember is that a lot of these thrombosis that we see in adults actually can occur after discharge. Most of the data that we have on pediatrics, however, is of patients who are in the hospital. So post-discharge, how much thrombosis happens in children, that is an area which has not really been looked at all.
Ma'am, will doing HSCRP help in detecting this thromboinflammation going on? High sensitivity CRP.
So it might help, but the trouble is, again, you don't know where the thrombosis is happening. But yes, I mean, if you're doing it for pulmonary veins, yeah, why not? You can look for pulmonary thrombosis. That could be a thing to do. But again, we don't really have data. And in adults, we have seen particularly patients who were admitted for pneumonia or abdominal surgery and other things, can actually have a thrombosis even 90 days after discharge. So, but unfortunately, all the data we have on pediatrics is of patients who are in the hospital. We don't have any data of outside. So I think that question of COVID, we don't really know all the answers about when these sudden deaths are happening. In the hospital, definitely always think about pulmonary embolism. But, if the deaths are happening outside, that's something I can't answer.
Ma'am, warfarin versus direct oral anticoagulant, which one should be the first choice in pediatrics? Are there any newer direct oral anticoagulants?
There are a lot of newer anticoagulants, and we have used all of them. And I can tell you, in the last 10 years, when rivaroxaban and apixaban and all these agents came, we were very excited. We said, okay, now we don't need to do PT-INR. It's going to be so nice and it's going to be so wonderful. But I actually feel that vitamin K antagonists still are the most useful and practical to use. There are several reasons for that. One is that we have had patients on the DOACs whose thrombosis is not resolved, right? So one of the reasons that I think we get a better response with vitamin K antagonists is because we can monitor the PT-INR and we can check compliance. If somebody on rivaroxaban or apixaban or dabigatran misses their dose, it's not easy to do a 10A assay or anything. And so you really don't know if they're being compliant or if they're, missing one dose a week or whatever. The second thing is that we were told that there is less risk of bleeding, and that is not true. In fact, we're seeing more bleeding episodes with the DOACs than with a well-monitored vitamin K antagonist. So, and then there's the cost, because if you are using it long-term, the newer anticoagulants are much more expensive than vitamin K antagonists, and doing a PT-INR at a government hospital is not an expensive test at all. So I'm actually kind of going back now to a lot of the, in even a lot of my adult patients, unless they specifically have a problem with doing the PT-INR monitoring. And in fact, we get a lot of patients referred to us from the private sector where they have been on the newer anticoagulants and they've not responded. And then we put them on vitamin K antagonists and we are able to get rid of the clot. So there's not really much benefit. The only thing is convenience. And if the family really is unhappy with the testing, there are, however, a subset of patients who have warfarin resistance. These are patients where you need to give very high doses of warfarin or acetrom. So even though we call it warfarin resistance, but you're acetrom resistant also. So, and this is due to certain patients who have inherited polymorphisms, which make them resistant to warfarin. So you may have some families where that is there. In those cases, then you can go ahead and use the direct acting anticoagulants. But otherwise, I really don't see any benefit to them. It's basically the companies that are kind of pushing. I see some hands raised. Dr.
Dr. Sriram, you want to ask something? Yeah, please.
Yes, ma'am. Good morning, sir, and good morning, ma'am.
Good morning.
2-3 points, sir. Morning for the management of superficial vein thrombosis. When to decide and how to decide to treat. And the second question, ma'am, just like a level we not do routinely the assay in the active phase. But if we done in the active phase and the level is normal, then it must be okay. It may be fastly low, but if normal, then it is most likely it is normal.
Agreed. So if it's normal or just slightly low, then you're not dealing with a deficiency. If it's absent, then you probably are dealing with a deficiency. So if you have a high index of suspicion, you can do it. The only reason I just mentioned that we don't usually do it is because we're not always thinking of protein C, protein S deficiency. And if it's low, don't label somebody as protein C, protein S deficient because you did the test and it's low. Same for 83. For superficial vein thrombosis, we do not anticoagulate. The treatment of superficial vein thrombosis is basically hot fermentation and maybe antibiotics if you think that they are infected. So, patients can have thrombophlebitis, they can have, varicose veins or other superficial thrombosis. See, you have to always remember when you're anticoagulating somebody, you're walking on a tightrope, you are actually putting them at risk for bleeding. And so for a deep vein thrombosis, yes, you anticoagulate. Superficial, never.
Dr. Anas?
Sorry, sir. So last one minute, ma'am.
Please continue, Dr. Siaram. Please
yes,
continue.
you already explained, ma'am. So younger kids still now the one word answer is enoxaparin if they afford and can arrange, ma'am. Any choice of anticoagulant, ma'am?
Well, enoxaparin is one. The other option is fondaparinux. The cost difference is not really that much. The advantage of fondaparinux is it's once a day. Enoxaparin would be twice a day. So that's one injection versus 2 injections. But otherwise, as I said, vitamin K antagonists can also be given, and enoxaparin or fondaparinux.
Okay, thank you.
Dr. Anas?
Dr. Anas, Dr. Kuppasamy, please unmute. Yeah, please ask your question.
Dr. Anas, you are not audible.
Maybe he can type it.
Dr. Kuppuswamy?
Anas, we can type in the question answer box.
I think we are done now. Any role of enoxaparin in neonates for portal vein thrombosis?
Yes. So I had shown that you can use enoxaparin in newborns. The dose is higher than what we give for 2 months and above. So it can be given. The only thing is if there's severe renal dysfunction, then you need to reduce the dose. So otherwise the newborn dose is higher, but if there's severe renal dysfunction, you need to reduce the dose. If avoid, or the other option that you can do is you can do a 10A monitoring to help adjust the dose. And we also have other low molecular weight products that can be used in a renal vein thrombosis. So if there's severe renal dysfunction, then we want to avoid enoxaparin, but it can be used if there's only mild renal dysfunction, but with monitoring.
Dr. Jagdish, your comments?
Hello, good morning. Dr. Tulika, compliments for a very comprehensive talk. In fact, your own experience of using the drugs, particularly there were a lot of questions regarding this, whether to give newer drugs or to give warfarin. And you said your own experience, you have seen that newer drugs are not all that great. And everything new is not going to be superior to the older things. So that thing is there. It was interesting to see the questions, the type of questions which came up, particularly that thrombocytopenia associated with thrombosis. And I think, Dr. Tulika, one another entity which, though very rare, but we do see in pediatric age group is TTP, where both things would be there. And particularly the very small children where it is congenital TTP because of ADMTS deficiency, their role of plasma would be there, FFP transfusion, and then going with the recommendation that you said, keeping the platelet at 50 and then going with the anticoagulation. So that is one thing I would like to add.
Completely.
Other thing I would like to stress is that you mentioned the infections being triggered, and one of the infections that we have seen is tuberculosis. A lot of cases, maybe 8-10 cases I might have seen. And while reviewing the literature, we see that in various studies on thrombotic parameters in patients with tuberculosis, there is something like 6 to 20 times increased risk of thrombosis in patients with tuberculosis. And we recently had a child in Faridabad, ESI Medical College, where a suspected COX patient had bilateral lower limb edema. Though I felt maybe she is malnourished and maybe there would be hypoproteinemia. But it was over a weekend. I told them that look at the proteins. If they are normal, get the Doppler done. And the Doppler showed both the lower limb major veins being occluded. So this was with tuberculosis, and with anti-tuberculosis treatment as well as warfarin, which was preceded by enoxaparin, the child is doing good. So tuberculosis is something which one should keep in mind. Thank you.
And the other issue with this patient is that often when they're on ATT drugs, the dose of warfarin required is very high in order to maintain a PT-INR. So what we do is we work with the TB medicine treating doctors, because often these patients will be on 10, 12, 15 milligrams of warfarin, but as soon as they stop the ATT, we need to reduce the warfarin, because the TB drugs actually metabolize the warfarin and lead to.
That's right. The dose would be required more. Yes.
So
Thank
you're
you.
very.
Thank you.
Thank you. Yeah, and Upshaw Shulman, which Sir talked about the congenital TTP, these patients, basically the treatment, now of course there's a purified Adams TS13 that's available, but that's very expensive. So the majority of our patients also get FFP, or you can give them the intermediate purity factor 8, which has some Adams TS13. So that can be given. If these patients have developed a thrombosis, then you must give the FFP along with the anticoagulation. And the FFP actually will lead to the platelet count improving. So rather than giving platelet transfusions, you give FFP and the anticoagulation in these patients, as Sir has rightly said.
Yeah, and I think the audience may be told that the diagnostics for this is available. One can get a molecular testing done for the diagnosis of this ADMTS deficiency.
And it can, we recently just had a 18-year-old who presented with TTP, but he somehow was not very sick. So I was a little confused, because usually, when you present with TTP as an older person, these patients are very sick. And then we investigated, and this was also a congenital TTP. And he had a few episodes earlier, but they were not picked up. So previously, my experience had been that they would be picked up when they were very young. And we actually have 3 children. One is in two in one family and one in another. But this was the oldest congenital TTP that we found. So I don't think it's as rare. I think it's missed.
That's right. Even thrombotic disorders, over the years, we have seen that there are increased number of patients requiring the antithrombotic treatment. Like I remember in Kalavati Hospital, which is a busy hospital, at one given time, maybe 5-6 patients were receiving anticoagulation. Maybe because of the lot of long lines are being used, and the other comorbidity patients are surviving long, and they are having, because of infection or whatever, they are having thrombotic lesions. Yeah. I'm glad you asked to include this as one of the topics in the program. Thank you.
No, it's all your guidance, sir. Thank you.
Ma'am, there is a question: what is the cause of thrombosis in ITP?
So ITP is also considered to be a pro-inflammatory state. There are many cytokines and other things involved. We don't exactly know. We do know that fatigue is one of the very important symptoms, and that has been related to cytokine alterations. The other thing is in some patients, mostly in adults, of course, it can also be associated with other autoimmune diseases as well. So we often have patients who can have SLE and other autoimmune diseases. So we don't know the exact cause, but it is considered to be one of the prothrombotic states.
So with this, we come to end of this session. I request everyone to fill the Google form and hope to see you all on 3rd of September.
Thank you.
Thank you, ma'am, for late night session from US.
Ma'am has joined from USA. It's a midnight over there, I think.
Yes. So
Thank you.
Thank you, ma'am. Thank you, once.
See you
Thanks,
everyone
ma'am.
on 3rd of September live.
Definitely. Thank you, sir.